coarctation of the aorta. This results from stenosis of the aorta, most commonly near the ductus arteriosus. Basically, the heart can't adequately pump against this narrowed aorta, which causes blood to backflow into the heart, and it results in left ventricular hypertrophy and heart failure. This leads to higher blood pressure in the upper extremities with lower blood pressure in the lower extremities. Infants with CoA usually present in acute distress, but if the coarctation goes undiagnosed into childhood or adulthood, presentation is generally milder because the collateral vessels form to help generate additional blood flow. Coarctation of the aorta is one of the most common congenital heart defects seen in clinical practice. It accounts for about 5 to 7% of congenital heart defects. As I said earlier, it can present at any age depending on the severity of the defect. There is an association with CoA in males. They're more commonly affected than females, 2 to 1. There's also an association with Turner syndrome. For clinical assessment, infants usually present acutely with severe acidosis, shock, heart failure. Children are more commonly incidentally discovered after either developing new early onset hypertension or a new murmur on physical exam. And adults usually present with hypertension, headaches, or claudication. For physical exam, there's a screening physical exam which involves simultaneous palpation of the brachial and femoral pulses, looking for a brachiofemoral delay. Delayed or diminished femoral pulses are highly suggestive of CoA. Screening also involves measuring the brachial and popliteal blood pressures. There's generally a large pressure difference between the two, with a higher pressure in the upper extremities compared to the lower extremities. Murmur that is continuous mid to late systole and best heard posteriorly between the scapula is indicative of CoA. However, in long-standing coarctation, the collateral vessels form, so the murmur is best heard in the lateral chest. For diagnosis, transthoracic echocardiogram is the study of choice. You can also order an MRI and CT to confirm diagnosis. These help aid in surgical planning as well. A chest x-ray in adults may show cardiomegaly, aortic enlargement, and rib notching if collaterals are present. And an EKG is often nonspecific, but it may show LVH in long-standing CoA. For treatment, definitive treatment is going to be surgery. There are currently 3 methods, including surgical repair, balloon angioplasty, and stent implantation. Surgical repair is the standard of care for infants who present in acute distress. This is an open surgical repair of the narrowed aorta. There's a variety of approaches. This is usually how you treat the patients that present acutely. Balloon angioplasty is questionably the best option for pediatric and smaller patients whose vessels have not reached maturity. More research is still needed in that area. And stent implantation has been accepted as preferred treatment for older adolescents and adults. This is often performed electively after diagnostic and surgical planning has been done. There's also conservative therapy used either during the interim of surgical planning or if the patient is not a candidate for immediate surgery. This includes lifestyle modifications such as reducing hypertensive complications, either with medications like beta blockers, ACE inhibitors, or ARBs. Also things such as smoking cessation, low sodium diet, weight loss. But this is not definitive treatment. And all the patients with CoA need CT or MRA at least every 5 years to screen for restenosis and aneurysm formation, which is a common complication. All these patients need lifetime follow-up with cardiology. So this has been my presentation on coarctation of the aorta.